For next session, I would like to call upon Dr. Saurabh Mukewar. He will be presenting management of gastroesophageal reflux disease. Dr. Saurabh Mukewar is senior gastroenterologist at Midas Hospital, and he is the organizing secretary for today's event. For chairing the session, I would request Dr. R.B. Karamkar sir and Dr. Hitesh Dudhe sir to please come on the dais.
Good morning. I thank Dr. Mukewar and API for asking us to chair this session. And we have very handsome, very well-spoken, young, dynamic gastroenterologist to talk on the common topic of gastroesophageal reflux disease. And this is very common. Retrosternal burning, and many times patients may present as chronic cough. You may not find any findings, and such patients you may be having GERD. So let us hear from Saurabh about GERD. Go ahead, thank you.
Okay, a very good morning all of you. It's wonderful to see a full house. Thank you all for coming from, I know a lot of you have come from a distance. So thanks again for coming and making this a success. And thanks Dr. Karamkar and Dr. Dudhe for being here. So today I'll be talking about gastroesophageal reflux disease, and I'm going to request all of you to have hands on the voting pads because there will be questions, and I want this to be an interactive session so that you all can participate in management of this case with me. So let's start with the case here. So this is a 33-year-old female who is having burning in chest and regurgitation for last 3 months. She's having this after eating spicy and fatty food, sometimes severe. The patient, she says, is unable to sleep from it. Anxiety, she's quite anxious. It's affecting her work. Now she's worried that she has a cardiac problem, no alarm symptoms, no weight loss, no dysphagia. She has a stressful job, drinks 2 to 3 cups of coffee a day, no tea, alcohol, or smoking. So I'm going to ask you the first question now. We'll have, what should be the next step? Advise an upper GI endoscopy, advise barium swallow, prescribe H2 blockers, prescribe proton pump inhibitors, or refer to a psychiatrist. And we'll open this for voting now. Okay, not bad. So the audience is quite smart here. Prescribe PPIs. Fair enough. Audience is not gastroenterologists, so you don't have to endoscopy everyone. So yes, prescribing PPIs is actually the correct answer. And this is based on prior studies where trial of PPIs can be done in GERD patients who don't have any alarm symptoms. And this is data from 15 studies, almost 2,800 patients, where you could try short-term PPIs versus compare that to an objective evidence of GERD, one EGD or pH-metry. And what is seen is 78% sensitivity, which means 8 out of 10 times you will successfully treat and pick up GERD patients with just a trial of PPIs. But it's not very specific, which means patient has a non-GERD etiology of symptoms. Almost half of them may still respond to PPIs. So therefore, it picks up the patients who have GERD reasonably well and can be a cost-effective strategy. All right, next question. What lifestyle modification has the strongest evidence for reducing GERD? I'm saying again, strongest evidence amongst these: elevation of head of bed, stopping smoking, weight loss, early evening meal, or increasing fiber intake. Now we can start the voting. So I'm sure all of them are important. Which one is the most important? Okay, so a lot of distribution here. So I can, I guess, assist in this. So the strongest evidence is for weight loss. All of them are important, but the strongest evidence is for weight loss. And based on this study, when you're looking at lifestyle interventions, weight loss in obese patients, that is, has level A evidence. Early evening meals, dietary fibers, elevation of head of bed, smoking cessation are also important. All right, so our case continues here. This patient, in view of typical presentation of GERD, was started on rabeprazole 20 milligrams a day and was advised for weight reduction. She has BMI of 33. So 4 weeks later, now she has about 40 to 50% relief, but she continues to have symptoms. Now again, a bit of a challenge. Now you've given her PPIs, she's not getting better. So what next? Okay, should you increase the dose to twice daily PPIs? Should you perform an upper GI endoscopy? Should you check for compliance and timing? Switch to a different PPI? Or continue the same dose PPI for 4 more weeks to hope that it starts working now? Perform EGD, all right, not bad. Well, I think it's a reasonable next step, but actually what we recommend is ensuring that next slide, please. Ensuring that the compliance and timing is important. And the reason is because when you ask patients, the problem is they may not take the PPIs the way they are supposed to. And here's the issue. If you look at this data from almost 610 PPI users, almost 30 to 60% are not taking it the way they should. It should be taken 30 minutes before meals and as prescribed, and that's the issue. So ideally you want to make sure that the patient is taking it correctly before doing any investigations. So let's say if you're not responding to OD PPI and you're compliant, trying a different PPI or increasing it twice a day is also reasonable. If a randomized controlled trial in patients who are not responding to once a day PPIs was switched to either twice a day dosing of the same PPI or a different PPI. So here's the study. And you see the patient was given lansoprazole, they did not get better. So they were asked to do it twice a day or switch to esomeprazole, and you can see the difference. Almost 80% had improvement in symptoms in both the arms. So both are reasonable things to do. You can either switch to another PPI or increase this to twice a day if they're not responding. So in our patient, we ended up doing an upper GI endoscopy. This was normal, a slightly loose valve, but otherwise was okay. No esophagitis. So now we continue the case. Now the drug compliance is good. She's taking 30 minutes before meals. We said, okay, now let's increase it to twice a day. Now she's given morning and evening. Okay, so now 4 weeks later, she says, I was great. I felt wonderful for 3 weeks. But then she says, now I still have problems. Now we're on 4th week, 5th week. She's saying, I just have trouble again. Okay, now what do you want to do next? Add baclofen, add alginates, add prokinetics such as domperidone, etopride, add H2 blockers when you go to bed, or do further testing with pH metry or esophageal manometry. We'll open this for voting now. Okay, let's see the results. Add prokinetics such as domperidone, etopride, okay, and 22% think further testing, okay. So the answer actually is further testing. And I'll go through the answers for you. So H2 blockers, yeah, gained some popularity adding ranitidine at night. And the idea was that it reduces your nocturnal acid breakthrough when you have acidity at night. The problem is tachyphylaxis. They develop tolerance over time. This is very clearly shown in this beautiful study. So initially it may work, but then later they develop tolerance. So H2 blocker is not a great idea. Topical alginates, which is Gaviscon and all these things to have additionally, works fine for nocturnal acid breakthrough. This is a research study looking at the data here. Initially it showed some benefit, but later really not so much benefit. So it doesn't work as well for these cases. Everybody thought prokinetics is the solution. So how effective are prokinetics? And you look at this meta-analysis, almost 1,500 patients. Adding a prokinetic for GERD patient will increase your symptom improvement modestly by another 10%. So 50% with BD-PPIs, 63% adding a prokinetic. So not great. Baclofen, actually interesting, reduces esophageal relaxations, which happens. So in this study, you see the acid reflux did not get better, but the duodenogastric reflux, which is non-acid reflux, actually can get better with baclofen. And this can be added in certain situations, but not entirely. So if you look at these add-on therapies, H2 blockers, tachyphylaxis is a problem. Alginates, very mild benefit with prokinetics. Baclofen is good for non-acid reflux, not for acid reflux. And ACG 2002 guidelines, the American College of Gastroenterology actually do not recommend any of these for these patients. You can add alginates in pregnant women, that is an option, but otherwise not great evidence to support this. So, okay, so we're looking at further testing, esophageal manometry and 24-hour pH metry. So how many of you are even aware of the fact that these testing exists for GERD? I mean, I can have a show of hands, I don't think there's a question there. All right, so esophageal manometry, and I'll show you here. So this is how it's being performed. This is a patient in the hospital, in fact, yesterday. Manometry, this is a test to measure the intraluminal pressure and coordination of pressures in the activities of the muscles of the esophagus. So this is how it's done. We put a tube through the nose, make the patient swallow, and we get these curves on the top. And it tells us how the esophageal muscle is contracting. And these are the curves that you get. And based on that, we can identify some motility disorders, achalasia being the most common type, and we can find different types of achalasia. So on that note, what proportion of patients with refractory GERD have achalasia? 1 in 500, 1 in 200, 1 in 100, or 1 in 50. So we can open for voting. Okay, interesting. So, so this is very widely distributed. The actual answer is 150. So this is the prevalence, and we see this quite a bit. Patients have been treated with GERD, not getting better. At least 5 patients with achalasia we diagnosed in the last year or two who were thought to be reflux all along. Endoscopy was negative. So this is the data, and if you look at this, overall patients who are not responding to PPIs, refractory GERD, 2% turned out to have achalasia. So it's not as uncommon as you may think. And the flip side, patients with achalasia can have a lot of GERD symptoms. Now look at this. Almost 50 to 70% of achalasia patients can have GERD-like symptoms. So there's overlap both ways. So you have to remember that. All right. And our patient, well, this did not have achalasia, should have a normal manometry. And then we did our 24-hour pH metry with impedance assessment. Now what it is exactly is that we measure 24 hours of acid. We put a nasal catheter, we ask the patient to have a normal life, eat, drink, report your symptoms, and we measure how much acid is coming in the esophagus. And we can also do impedance testing. And impedance testing basically is like an electrode with current. So anything, say liquid, acid comes up, it lights up. So basically impedance tells you the volume that's coming up. And what we do is a combination of 24 hours of acid measurements as well as impedance in these patients. Now when you do this is performed, another question for all of you, when pH metry test is performed, it should be always done in patients while you're off the PPIs. You should always do it when you're taking PPIs. Or it can be done either way, on or off PPIs, depending on the clinical indication. And taking PPI does not impact the result of the pH metry. All right, voting please, yeah. Off PPIs. Okay, that's reasonable, but actually, when we treat these complex patients, we end up having a different issue. It can be done both ways. Next, please. It can be done either way. It doesn't always have to be done off PPIs. And that's the reasonable thought, to do it off PPIs to really truly understand GERD, but we have to do it sometimes on PPIs. And here's the reason. Well, scenario one, when the patient actually, GERD has been documented, had erosive esophagitis, and the patient has symptoms, we do it on PPIs. Because we don't know if the PPIs are working completely for the patient. So if the patient has erosive esophagitis, got PPIs, not better, is it because the PPIs are not working or not effectively controlling acid? Other scenario, we don't know. We did a trial of PPIs, we don't know what this patient has. In that case, we do off PPIs to confirm whether we are truly dealing with GERD or something else completely. And when we look at this, we can have different scenarios, and I'll just go through the basic stuff. Positive pH metry test, which means the test says it's positive, there is stuff coming up, it can be acid, which can be picked up on the pH metry, or it can be non-acid, which means the PPIs worked, acid reduced, but there was non-acid reflux, like bile and stuff was coming up. Or you can have negatives test, when they say there's nothing coming up. And that, when the symptom is present with physiological reflux. Now, all of us have some reflux of contents coming in the esophagus, and it's called reflux hypersensitivity. And without that, it's functional heartburn. And I'm going to just quickly go through it in the interest of time. Patient ended up having off and on PPIs, our patient. You can see before the off PPIs, you can see this patient clearly had reflux, 5.2% acid exposure. On PPIs, it reduced. But this patient had non-acid reflux episode. So the patient's PPIs were working, but there was non-acid bilious reflux, and that's the reason why this patient was diagnosed with GERD with non-acid reflux while taking PPIs. We can have various options, endoscopic and surgical. I'm just going to quickly go through this. So what we ended up doing in this patient was called anti-reflux mucosal ablation. That's a new technology that new technique for treating reflux patients, where we go with endoscopy, ablate the lining of the stomach, and what that ultimately leads is, I'm just going to take 30 more seconds. And at the end of this, you can see the scarring resulting in tightening of the GE junction, and acid reflux reduces in this patient. And I'm going to skip this data right now. But it works about 60 to 70% of the patients overall. And our patient is doing well 6 months post-ARMA, with 2 to 3 times she had to use PPI. So in conclusion, trial of PPIs can be considered in suspected GERD. Lifestyle changes are important. Ensure compliance and PPI timing. Add-on therapies are not very effective. Manometry, pH metry in refractory cases. Rarely, refractory GERD can be from esophageal motility disorders, and endoscopic therapies are effective for GERD. And thank you. I'll end the session there. Yes.
That's a very nice presentation, sir.
Thank you.
You have included right from the beginning, from the patient, how the patient presented, how to evaluate, how to start the treatment. My question is, sir, many times with a patient is on continuous treatment, despite all these things,
yes,
sometimes there are other endoscopic procedures are also mentioned, like RFA or endoesophagus is there. And what you are saying is arms.
Yes,
so
ARMA.
if all these, considering all these procedures, what do you think, which procedure is better if patient is not responding despite everything?
Yeah, no, I think that's a very relevant and very important question, because I think most of the patients do end up responding to reflux treatment, as all of you must have experienced while treating. Issue is well characterization, where we are not doing these advanced procedures in patients who have psychological comorbidities and reflux hypersensitivity or functional heartburn. So once that's ruled out and we are truly dealing with reflux, so you'll have two scenarios. One, the patient has responded and wants to stop PPIs because of concern that it may cause long-term damage, or says, I just don't want to take them anymore. So that's a true, correct patient. You do a procedure, will likely benefit, doesn't have psychological issues. And the second one is when they have volume reflux, PPIs reduce the acid, and there's volume that's coming up. And amongst options for the procedures, you have one, if you have large hiatal hernia, endoscopy is not your solution. Surgery is the way to go. Second scenario is where you don't have a large hiatal hernia and it's slightly loose. In that scenario, you have various options. The cheapest is ARMA, which works in our patient population. Other things like GERD-X, etc. are available, but they cost about 2 to 3 lakhs. Most of our patients end up don't wanting that. in fact, when I even offer ARMA to patients, 8 out of 10 still want PPIs. So that's my experience, but they can be offered, yes. Thank you.
Any questions from our audience?
Just would like to have a comment that whenever the patient is not responding to routine PPI, then it is more of non-acid reflux than the acid reflux. So, you know, apart from when it's a non-acid reflux, there you have what is called as functional heartburn or reflux hypersensitivity. So in clinical practice, when you do single dose PPI, not responding, rule out endoscopy, organic disease, give double dose PPI. If not responding, or you may add baclofen and amitriptyline as a combination. So that's, will respond most of the patients. And even if that doesn't respond, or there is a regurgitation as a predominant, which is called as volume reflux, these would require therapies to strengthen gastroesophageal reflux, either in the form of endoscopic treatment or in the form of surgical intervention. The commonest indication for surgical treatment is volume reflux. Whenever these fluid comes, regurgitation, volume reflux, response to PPIs is less with that.
Yeah, and I think other organic diseases, like as we discussed,
Achilles has to
motility,
be-
there can be eosinophilic esophagitis, which has to be picked up on biopsies. But the fact is, 8 out of 10 will probably have some degree of psychosocial, psychological comorbidities, resulting in hypersensitivity and functional heartburn issues. So that I think is frankly the most common thing. Okay. Close the session. Thank you. Thank you.
Thank you very much, Dr. Saurabh, for a very informative talk. Thank you, chairpersons. Now, shortly, we will be proceeding with inauguration ceremony. I request Dr. Saurabh Mukewar, sir, organizing chairperson, to accompany today's chief guest, Dr. Gopal Dubey, sir, to the dais.